everyone. We're going to talk about musculoskeletal disorders, and we are Taylor, Sophia, and Sandy. First, we'll be talking about Myasthenia gravis. This is an autoimmune disorder where the body attacks its own neuromuscular connections. So this affects communication between the nerve and the muscles. It's most commonly found in females ages 20 to 30 and males over 50. It is more common in males. It can also be seen in newborns if antibodies are passed from a mother who has this to a fetus. However, this is temporary. Symptoms include drooping eyelids called ptosis, double vision called diplopia, and muscle weakness, fatigue, difficulty swallowing and speaking. So it just affects all of the muscles in the body. It is most commonly diagnosed by antibody blood test, testing the anti-acetylcholine receptor. It's also diagnosed by nerve conduction studies or electromyogram. In the literature, it was shown that some providers just diagnose it if a patient has these symptoms and they give them the medication for it and the patient improves, then they consider that the patient has MG. For treatment, there is no cure for this, but giving the medications that affect these synapses at the anticholinesterase locations. Steroids also help. Immunosuppressives to help with the attacking on the autoimmune portion of the body. These are all lifelong. And as nurse practitioners, we want to recommend that these patients take medications an hour before eating so they have full strength to eat. Patients can also get a thymectomy, which is the removal of the thymus gland, which stores the T cells. They can also get plasmapheresis, and it's removing the patient's plasma, so removing the antibodies from their blood and then replacing it with donor plasma. They can also get immunoglobulins to decrease the immune system response.
Okay, so now we're going to talk about osteoporosis. Osteoporosis is literally translated to porous bone. It's the most common bone disease in humans, and it's characterized by low bone mineral density, or BMD, impaired structural integrity of the bone, decreased bone strength, and elevated risk of fracture. The lower the BMD, the higher the risk for fracture. There's also two types of osteoporosis. Primary or idiopathic is the most common, and then secondary osteoporosis refers to osteoporosis that it's caused by other conditions. These can be like endocrine diseases like diabetes, hypothyroidism, medications like corticosteroids, or other substances like alcohol or tobacco. Throughout the lifetime, there's a constant process of resorption and formation of the bone. Old bone is removed in resorption and new bone is added in formation. So during childhood and the teenage years, new bone is added faster than the old bone is removed, and this leads to larger, heavier, and denser bones. Peak bone mass, or the maximum bone density and strength, occurs around age 30, and then afterwards, bone resorption begins to slowly exceed bone formation. There's a balance between bone resorption and formation, and it's due to osteoclasts and osteoblasts. So osteoclasts are responsible for the resorption and osteoblasts are responsible for the formation. They're dependent on each other for production and are both linked to the process of bone remodeling. In osteoporosis, the old bone is resorbed faster than the new bone is being made. Various factors can cause issues with the mechanism that controls bone resorption and formation. The mechanism between osteoclasts and osteoblasts is unable to keep up with different microtraumas to the bone. So this leads to bone losing density, becoming thinner, and becoming more porous. Eventually, the skeleton is no longer able to support itself, so the bone becomes more fragile and fractures more frequently. The fractures can occur from falls or bumps that would not have previously caused fracture, or even just fracture spontaneously. So here are various risk factors for osteoporosis, different genetic ones like increased age, white or Asian ethnicity, female gender, family history, hormonal or metabolic is obesity, early menopause, or hyperparathyroidism. There's different dietary risk factors like anorexia, high caffeine intake, or low calcium or vitamin D. Sedentary lifestyles, smoking, or excessive alcohol intake can cause an increased risk of osteoporosis. Different conditions like diabetes, hyperthyroidism, rheumatoid arthritis, and different medications like corticosteroids, heparin, or different thyroid medications. So the most common manifestation is bone deformity. We also see vertebral collapse due to the weak and brittle bones. So you may see kyphosis or a hunchback look and diminished height. People with osteoporosis won't necessarily have pain, but pain tends to occur only when there is fragility fractures, but you will see increased fractures. The most common, as stated above, is vertebral fractures, and the most life-threatening tends to be hip fractures because of the resultant chronic pain, disability, diminished quality of life, and premature death due to complications like PE, hemorrhage, or shock. Our patho book stated that approximately 20% of persons with a hip fracture die as a result of surgical complications. So bone density testing is based on standard deviations that differ from a mean mineral bone density of a young adult. So they use a reference population, and they come up with a number known as the T-score. Normal bone density is T-score greater than or equal to -1. Osteopenia is a T-score between -1 and -2.5, and osteoporosis is less than or equal to -2.5. And this is used to guide interventions and treatment. A DEXA scan is the current exam of choice for osteoporosis diagnosis. It stands for dual energy X-ray absorptiometry, and it's where two low energy X-ray beams show the bones. It measures bone density, but it doesn't necessarily provide much information about bone strength or fracture risk. And by the time abnormalities are able to be detected by X-ray, often 25% to 30% of bone tissue may have been lost. The National Osteoporosis Foundation recommends bone density testing for women 65 plus and men 70 plus. If a patient breaks a bone after age 50, women of menopausal age with risk factors, postmenopausal women under age 65 with risk factors, or men aged 50 to 69 with risk factors. It also may be necessary if the X-ray of the spine shows a break or bone loss, back pain with possible vertebral fracture, height loss of greater than ½ an inch or more within 1 year, or a total height loss of 1.5 inches from the original height. People taking osteoporosis medications should do repeat bone density testing every 1 to 2 years. And after starting a new medication, healthcare providers will often repeat bone density testing in 1 year. So the goals of treatment are preventing fractures and maintaining optimal bone function. There is a role of calcium intake to prevent and treat osteoporosis, but it is controversial. Adequate oral calcium intake during adolescence is shown to be very important. However, there's no clear-cut positive clinical outcomes from the recommendations that were previously put out for calcium and vitamin D intake. And so they have concluded that postmenopausal women should not take calcium and vitamin D to prevent fractures. At the doses that were recommended, there is no benefit shown of a lowered fracture risk, and there is an increased risk of renal stones. So for non-pharmacologic interventions, as a provider, you should encourage diets with higher fruit and vegetable intake, as they are correlated with higher bone mass density. Regular, moderate weight-bearing exercise can also slow the rate of bone loss and in some cases even reverse demineralization of the bone. There's also several options for pharmacologic management. Selective estrogen receptor modulators like tamoxifen help to provide positive effects of estrogen to the bone, but minimize some of its negative effects on breast and endometrial tissues. Biphosphonates bind bone mineral and improve osteoblast and osteocyte survival, which slows the bone remodeling process. And they're the mainstay of osteoporosis treatment because they're very effective at reducing osteoporotic fractures. Denosumab is a new and promising treatment that helps to reduce bone resorption, and teriparatide is a biosynthetic form of parathyroid hormone that stimulates osteoblasts and reduces vertebral fractures. It's an option if candidates are not, or if patients are not candidates for biphosphonates. It's given by subcutaneous injection, but it cannot be used for more than 24-month period because it increases the risks of osteosarcoma. Okay, so our up-to-date article was about differential diagnoses of myasthenia gravis. It focuses on some of the differential diagnoses, such as conditions that mimic ocular myasthenia. It talked about how we should not diagnose myasthenia gravis without specific antibody testing because the patient could be misdiagnosed. They could have thyroid issues causing ophthalmopathy, myotonic dystrophy, brainstem, and motor cranial nerve pathology. It also talks about how ALS mimics the symptoms of myasthenia gravis, and medication toxicity of penicillin and statins can cause temporary myasthenia gravis symptoms. And here are our references. Thank you.